My roll number is 79. My topic is fracture of pelvis. Before I start my presentation, I would like to start with the quote. Believe you can, and you are halfway there. You all must be having questions like what is pelvis, parts of pelvis, structures related to it, and important nerves, and how to read a normal X-ray of a normal pelvis. So these will be the topics I will be covering in this presentation: relevant anatomy, classification, pathoanatomy, diagnosis, treatment and complications. As you can see here, here's a diagram of pelvis where I will be denoting the parts. Number 1 will be the sacrum, number 2 is the iliac, number 3 is the ischium, number 4 is the pubis, number 5 is the pubic symphysis, number 6 is the obturator, is the acetabulum, number 7 is the obturator foramen, and the number 8 is the coccyx. To understand it more easily, this is a simplified diagram where you can see the sacrum is connected to the attached to the ilium through the sacroiliac joint. Here is the ilium, sacrum, superior pubic ramus, ischium, inferior pubic ramus, obturator foramen, and pubic symphysis. Since through the acetabulum, proximal part of the femur gets connected, so the proximal femur parts are the greater trochanter, head of the femur, neck of the femur, and lesser trochanter. Here is a anterior posterior view of the pelvis. This is a normal pelvis. There is no pathology here. So in this normal X-ray, we will try to identify the structures. So this will be the ilium. Here is the sacrum. Here will be the coccyx. This is the acetabulum. Here is the ischium, superior pubic ramus, inferior pubic ramus. Here will be the pubic symphysis, and this is the head of the femur attached to the acetabulum. Here you can see the greater trochanter. Lesser trochanter is barely visible. So normally the head of the femur gets attached to the acetabulum like this. So here in the AP view, as you can see, the lesser trochanter is barely visible. But if there will be any deformity, like if there is external rotation, so the lesser trochanter will be more conspicuous, meaning it will be more visible. Whereas if there will be internal rotation of the head of the femur, then in the X-ray, the lesser trochanter will not be visible at all. Also, we will be talking about the Shenton's line, which will help us to identify any abnormality where Shenton line will get disrupted if there is any arthritis, neurovascular, avascular necrosis, dislocation or fracture. As I was saying earlier, we can identify these structures now easily in the X-ray. That is a sacroiliac joint, acetabulum, superior pubic ramus, ischium, inferior pubic ramus, pubic symphysis, shaft of the femur, lesser trochanter, obturator foramen, greater trochanter, head of the femur, sacrum and ilium. Now, as I was saying earlier about the Shenton's line, the Shenton's line is an imaginary line that passes through the inferior border of the superior ramus, goes through the neck of the femur till the lesser trochanter. So here is the X-ray. Let's try to find out if there is any abnormality in this X-ray. Now we will start from the basics. We will try to make a Shenton's line. We will start from here, from this inferior border of the superior pubic ramus. We will try to make a line which will go to the lesser trochanter. Here it is uniform. We will try to make this side. If we try to make this side, you can see it will be deformed. I will show you in the next slide. As you can see, you can easily identify that there is some abnormality here. So there is disruption of the Shenton's line. Also we could see is there is dislocation of the head of the femur here. Now in another X-ray we'll try to find any abnormality. Again we'll try from the basics, that is we'll try to make a Shenton's line first. So from the inferior border of the superior pubic ramus we'll try to make a line that goes through the lesser trochanter of the femur. Same we'll try to make this side. Here we could see there is some disruption over here. We could see there is some disruption here, that is a fracture of the head of the femur, neck of the femur. As I was saying earlier, now it is more visible. Now coming to pelvis. So pelvis has pelvic ring that consists of pubic symphysis, pubic crest, arcuate line of iliac bone, ala sacrum, and sacral promontory. So stability of the pelvic ring, how it happens. So anteriorly by pubic symphysis, supported by the ligamentous fibers above and below, whereas for the sacroiliac joint, there will be anterior sacroiliac ligaments and the posterior sacroiliac ligaments. Also, there will be some accessory ligaments like iliolumbar ligament, sacrotuberous ligament, and sacrospinous ligament. So here it is more visible. This is sacrum. There is anterior and posterior sacroiliac ligament. In the pubic symphysis also you could see above and below will be the ligamentous fibers. So important nerves that pass through the pelvis are obturator nerve and the sacral plexus. It pass over the ala of the sacrum and cross the pelvic brim. So ala of the sacrum is this part and pelvic brim is this. So here you can see obturator nerve and sacral plexus. Now, why it is important to know about the pelvis fracture? Most commonly, it is not a common fracture to occur, but usually in road traffic accidents, pelvis fractures usually happen. So therefore, it is important for us to know about pelvis fractures. So, Tyle's classification is there. Basically, divides pelvic fractures into stable and unstable fractures. In more detail, we can see type A will be the stable fractures. I will be talking about them in further slides. So A1 will be fractures of the pelvis not involving the ring. A2 will be stable, minimally displaced fractures of the ring. Type B will be rotationally unstable, vertically stable. B1 that is open book. B2 will be lateral compression ipsilateral. B3 will be the lateral compression contralateral. And type C will be rotationally and vertically unstable, unilateral, bilateral, and associated with acetobular fractures. So type A, that is the stable fractures. These are the isolated fractures, could be the parts of the pelvis, that could be the wings, could be the ischium, ilium, anterior superior iliac spine, and anterior inferior iliac spine. Basically, pelvic ring is not involved in this. So, for example, there is Duvernay's fracture, where there will be the fracture of the wing of the iliac will occur. Now we try to see the X-ray of it. So here we could see there is a fracture at the wing. This is a Duvernay's fracture X-ray. Straddle fracture. So there will be superior inferior ramus fracture of pubis. So bilateral superior inferior pubic ramus gets fractured. The patient may complain of pain and tenderness over the fracture site. Bed rest for 3 weeks is sufficient for the reunion and only treatment of pain is done. Now coming to type B, that is unstable fractures, which are rotationally or horizontally unstable but vertically stable. So force from the front in the anterior posterior direction leads to the opening of the pelvis. This is the hemipelvis. So there will be another hemipelvis joined by the pubic symphysis. So what will happen is if there is a force coming from the anterior posterior direction. What does it mean? From the anterior, from the front, the force will hit, which will lead to the dislodge of the pubic symphysis, leading to the opening of the this pelvic opening, which would lead to horizontal instability. So, as I was saying earlier, for example, if a car hits a person from the front, the pubic symphysis gets hit, there is pelvic opening, so there will be horizontal instability. Here is the X-ray. Here also you can see there is no pubic symphysis here, and there is an opening, pelvic opening. Type C will be the unstable rotationally and vertically, where lateral compression of the pelvis which occurs due to the force from the side. So suppose a person is standing to the side of a wall. So if a car or some object comes and hits the person to the lateral, so there will be lateral compression, where there could be two types of fractures in the pelvis. One will be vertical like this, and one will be a little slanted, but this will also be vertical. So this is Malgagne's fracture, where ipsilateral from the same side sacroiliac joint will be disrupted and the superior inferior ramus will be fractured. So there will be vertical instability. Here's the X-ray. We can find there is fracture here in the superior pubic ramus, inferior pubic ramus, and the sacroiliac joint. Here is bucket handle fracture, where there will be contralateral sides. So if superior and inferior pubic ramus of this side is fractured, so contralaterally sacroiliac disruption will occur. There will also be a vertical displacement. Again, X-ray, where we could see pathoanatomy. If a portion of a pelvic ring is broken and the fragments displaced, there must be a fracture dislocation in another portion of the ring. The following combinations of fracture and dislocation in anterior and posterior half of the pelvis may occur. For suppose anteriorly fracture of superior and inferior pubic rami occurs, then posteriorly fracture through ala of sacrum or dislocation through sacroiliac joint may occur. Similarly, if anteriorly disruption of pubic symphysis occurs, then posteriorly fracture through the ilium may occur. This is due to the instability. So what could be the consequences of pelvis fracture? There could be massive bleeding, around 1.5 to 2 liters of blood. In a normal human body, there is around 4 to 5 average 4 to 5 liters of blood. Imagine in a medical student, there must be even more less volume of blood. So this bleeding could be due to soft tissues around the pelvis, mostly urethral injury, venous plexus around the pelvis, and cancellous bones which are having rich supply of blood. So as pelvis fractures usually occurs in the RTA, it is important for us to know the emergency management. So A, B, C, D, E, where A is airway, breathing for B, C is circulation, that is stop bleeding and resuscitate. So we will focus on this part. D is disability management, checking if the person is conscious or not, and exposure control, that is log holding, and examining the person from tip to toe for any injuries. So venous plexus hemorrhage usually occurs, where in veins there is no vasospasm. So they will be bleeding continuously, as in comparison to arteries which get vasospasm. So internal bleeding can be stopped by pelvic tamponade, as vessels get compressed by using pelvic binders. So what is tamponade? Tamponade means pressurizing. So pelvic tamponade is we are trying to pressure to the veins of the iliac, and we are trying to put a pressure on it. I'll be discussing about it for the few slides. So in case of emergency, bed sheets, scarf, even dupatta, anything you can grab, you can use it as a pelvic binder. Then after that, giving IV fluids or blood transfusion for the lost volume. And when the patient reaches the hospital, external fixators in compression mode can be used. I'll be talking about it in further slides. So as I was saying, this is the pelvic binder, and in case of emergency, we can use a towel, bed sheet, or even a dupatta to control bleeding, as the person could get into the hypovolemic shock. So it may be one of the fractures where usually in RTA, it may be one of those fractures where the surgeon or the doctor would focus on other injuries rather than looking at if there is fracture of pelvis or not. So it may be one of those fractures in a seriously injured patient where the surgeon's attention may be diverted to other injuries with more obvious manifestation. A pelvic fracture must be carefully looked for in all the cases of road accidents, especially in those with multiple injuries, those associated with hypovolemic shock and those with the major lower limb fractures. The pelvic compression test is a useful screening test in all such cases. So to assess this, we will do pelvic compression test. So the patient is made to lie in a supine position. The examiners compress both the iliac crest and together. And if there is any springy feelings, this could indicate that there is a pelvic fracture. Radiological examinations can also be done for better evaluation. That includes hip X-ray, anterior posterior view. 3D CT scan is much better as we get more detailed radiological results. So treatment, the importance of the treatment of pelvic fractures lies in identifying the possibility of life-threatening hypovolemic shock and associated visceral injuries, as I have discussed earlier. The patient should be moved as little as possible, as movement at the fracture site may result in a further bleeding or fat embolism. Further treatment of the pelvic fractures depend on the type of fracture and presence of associated complications. So, if an injury with minimal or no displacement, bed rest is fine for 3 to 4 weeks. Once the fracture becomes sticky and the pain subsides, gradual mobilization and weight bearing is permitted. It takes around 6 to 8 weeks for the patient to be up and about. Injury with the anterior opening of the pelvis, that is the open book injury. Here, a minimal opening, if there is less than 2.5 cm of the pelvic opening, there is no need of surgery. Bed rest and later weight bearing can help in the reunion. If more than 2.5 cm of opening is present, then manual pressure at the iliac wings can be put so to close the pelvic ring. So how to close the pelvic ring? That is by manual pressure. Also by using reduction, by achieving the reduction in the following ways. So we can use external fixators like shank pin. They are inserted at the wings of the iliac. After manually reducing the displacement, the shank pins are clamped onto the metal rod. Hammock sling traction. This is now obsolete due to the problem in nursing. It is a popular method in the past. The patient requires prolonged hospitalization in this. So injuries with vertical displacement. These are the most difficult pelvic injuries to treat. These are treated by bilateral upper tibial skeletal traction. I will be showing you the image. Heavy weight up to 20 kg may be required to achieve this reduction. After 3 weeks, the weight is reduced to about 10 kg to maintain the position. The traction is removed after 6 to 8 weeks and the patient is mobilized. So here is the upper tibial skeletal traction. So in summary, if there is a ring disruption injury, treat the shock and stabilize the patient. Clinical and radiological assessment of the type of injury is to be done. Then emergency treatment of any associated complication has to be done. Then treatment of the fracture will be per se minimal or no displacement like stable fractures. So bed rest and analgesics will do the work. Now for displacement present, that is the unstable fractures. So anterior opening type, if less than 2.5 cm, bed rest and analgesics. If more than 2.5 cm, close reduction. Maintenance for 6 weeks by traction, external fixation and internal fixation. Vertical displacement, reduction by bilateral skeletal traction for 6 weeks and bed rest. Then open reduction and internal fixation and then bed rest. So what could be the complications of the fracture of pelvis? Rupture of urethra, commonly injured in males. Urosurgeon should be sought the treatment by draining the bladder by suprapubic cystectomy. Rupture of the bladder, repair the bladder, drain the bladder. Injury to the rectum and vagina. Gynecologist and general surgeon handle such complications. Injury to the major vessels can occur. Aggressive management is done. Vessels are ligated and repaired. Injury to the nerves may occur, so treatment is conservative. So now this is an MCQ. A patient has sustained a pelvic fracture in RTA, is bleeding as in shock. What would be the immediate management for this case? Should be exactly tie a bed sheet around the pelvis to prevent blood loss and to prevent hypovolemic shock. Most serious complication of pelvis fracture is correct. The references I have taken for this slide are Maheshwari and Mhaskar. Thank you.